Hi there, Dr. Holly Rizzo here. Welcome back to our lecture series in pediatric dentistry. Today we'll be discussing pediatric oral medicine and pathology. So let's jump in. First, we'll start with common neonatal oral lesions. So what do we mean by neonatal? So neonatal refers to the newborn period, which is the first 4 weeks after birth. During this period and beyond, some unique oral phenomena can occur, including Epstein's pearls, Bohn's nodules, congenital epulis, natal and neonatal teeth, and eruption hematomas or cysts. First, let's jump into Epstein pearls. So these are considered a common condition and occur in up to 75 to 85% of all newborns. These are small keratin-filled cysts that clinically appear as whitish or yellow in color and are smooth. Typically, the size is about less than 3 millimeters in diameter, and it's located at the median palatal raphe or at the junction of the hard and soft palate. The location is typically at this median palatal raphe, so that's really important to know for the board's exam. Epstein pearls develop in newborns during the early months of development, and it's typically a result of trapped epithelial remnants along the line of fusion of these palatal halves. So Epstein pearls are asymptomatic and don't cause discomfort or interfere with feeding. So no treatment is typically required, and eventually these will dissolve on their own within 1 to 2 weeks of birth. Next, we'll discuss bone nodules. So these have some similarities to Epstein pearls, but they do have some differences as well. So first, they appear white and firm on palpation, and they're also keratin-filled cysts. When it comes to size, they're similar, and they're also less than 3 millimeters. So Epstein pearls result from the epithelial entrapment during palatal development, while Bohn's nodules are believed typically to be remnants of the salivary gland. When it comes to location, bone nodules are often found on the alveolar ridge in the buccal and lingual aspects. Like Epstein pearls, there's no treatment required for this, and Bohn's nodules typically disappear on their own. So next we'll talk about congenital epulises. This is also sometimes called a granular cell tumor. This is a rare benign tumor of the oral cavity, which is only found in newborns. Like the image we see here, you'll almost always see this on the anterior maxillary ridge, and it's kind of this firm protuberant mass. This is important to know for the board's exam. Now, the thing about the congenital epulis is that it may contribute to mechanical obstruction that can result in respiratory distress and difficulty in feeding. For this reason, we will want to surgically excise this, and the newborn will typically heal well without any further complication. Next, we're going to talk about a really fun topic and one of my favorites, and that's natal and neonatal teeth. So it's important to touch up again on the definition of natal and the neonatal period so we can identify the correct terminology for the boards. So natal teeth are those that are present in the infant's mouth at the time of birth, while neonatal teeth are those that erupt during the first 30 days of life. Although the occurrence of both of these is rare, natal teeth are more common than the neonatal teeth. And more often than not, you'll find that most of the affected teeth are mandibular primary incisors. So treatment will vary for these based on symptoms and concerns of the family. So if the natal or neonatal tooth is not excessively mobile and not causing feeding problems, it should be preserved and maintained in a healthy condition if possible, and close monitoring would be indicated. However, if the tooth is excessively mobile, it may cause an aspiration risk or it may cause damage during function. We may want to consider extraction in this case. However, we want to be very careful for the potential risk of hemorrhage and make sure that the baby has received their vitamin K injection. Some potential complications of natal teeth include rigofide disease and aspiration. Rigofide is a medical term for when the natal or neonatal teeth ulcerate the ventral surface of the tongue, because sometimes the edges of these teeth can be quite sharp. So in this case, as long as it's not excessively mobile, we can consider smoothing the edges or extracting the tooth entirely. The last pathological finding that we'll discuss today is an eruption cyst or hematoma. So think of this as a soft tissue translucent swelling that results from a separation of the dental follicle from the crown of the erupting tooth. So the color can typically range from blue, black, brown, or purple, and the most common location is the mandibular molar region. So you'll find that more often than not, no treatment is necessary for these, and the tooth will erupt through the cyst spontaneously. However, if the cyst does not rupture spontaneously, this could cause issues with function, or the lesion could come infected, and this may require surgical excision. Okay, so now that we discussed common oral lesions that can be found in our very young patients, for the next part of the presentation, we'll be discussing common developmental and inherited conditions for children that are high-yield topics for the board's exam. So let's get started with Down syndrome. So, Down syndrome is a chromosome disorder that typically is due to a trisomy of the 21st chromosome. And this basically means that each cell in the body has three separate copies of chromosome 21. Because of this, you guessed it, it's called trisomy 21. And there's a few other variations to keep in mind. So, there's translocation Down syndrome, where there's an extra portion of chromosome 21 present, while mosaic Down syndrome is where only some of the types of cells have three copies of chromosome 21 present while others have two copies of 21 present. With that said, you'll find that all of these types share similar physical features and behaviors. So, one factor that increases the risk of having a baby with Down syndrome is maternal age. So, women who are 35 years or older when they become pregnant are much more likely to have a pregnancy that's affected by Down syndrome than women who are pregnant at a younger age. And there are certain clinical features that are commonly found in patients who have Down syndrome. This includes a smaller stature, eyes that are slanted upwards and outwards, a flat nasal bridge, macroglossia, and atlantoaxial instability. Next, we'll discuss autism. So, autism spectrum disorder is a developmental disability caused by differences in the brain. So, these diagnosed often have problems with social communication and interactions, as well as restricted and repetitive behaviors. So, it's really important to note that autism is a spectrum, which means that there's a wide range of symptoms, as we can see on this diagram. You may find that your patients have limited social communication or interaction skills. For example, they may avoid or struggle to keep eye contact or facial expression, and they may refrain from participating in interactive games with you. Others may have restricted or repetitive behaviors or interests, such as obsessive interests, repeating words or phrases over and over, and unusual reactions to sounds, tastes, and different textures. Certainly, a wide range of characteristics and features can be appreciated in this population. And next, we'll discuss fetal alcohol syndrome. So, this results from alcohol exposure during the mother's pregnancy. There's no specific amount of alcohol that's known to be safe to consume during pregnancy. If you drink during a pregnancy, you place your baby at risk of fetal alcohol syndrome. So, this may cause brain damage and growth problems, and again, these defects are irreversible. Some common defects include the following. So, distinctive facial features, including small eyes, an exceptionally thin upper lip noted here, a short upturned nose, and smooth skin surface between the upper lip and the nose. We can also appreciate deformities of the joints, limbs, and fingers, slow physical growth before and after birth, vision difficulties or hearing problems, a small head circumference and brain size, heart defects and problems with the kidneys and bones, poor memory and judgment skills, poor balance, learning disorders, and poor social skills and trouble adapting. So next we'll discuss obstructive sleep apnea. And this is when breathing is partially or completely blocked repeatedly during sleep. Most commonly, this is caused by enlarged tonsils and adenoids, which is an underlying factor, as well as other factors such as obesity, craniofacial anomalies, neuromuscular disorders that can also contribute. So treatment may depend on the following etiology. So this can affect the child's growth, cognitive development, and behavior. During nighttime, the signs and symptoms of pediatric sleep apnea include snoring, which is a very important symptom because infants and young children don't always snore, including also pauses in breathing, restless sleep, snorting, coughing, or choking in the middle of sleep, mouth breathing, nighttime sweating, bedwetting, and sleep terrors. While during the day, the signs and symptoms include performing poorly in school, difficulty paying attention, learning problems, behavior problems, poor weight gain, and hyperactivity. So let's jump into some questions. So, question one is which of the following is the most common cause of obstructive sleep apnea in children? So, take a moment to pause and think about this one. So, the correct answer to this question is option B, enlarged adenoids. Enlarged tonsils and adenoids are the most common cause of obstructive sleep apnea in children. Moving on to question number two. This is a 1-year-old patient who comes in with a bluish color swelling on the ridge. This patient does not have any other medical conditions. There's also a swelling in the soft tissue, and we can see this clinical photo attached. So, which is the most likely condition found in this patient? So, take a moment to pause and think about this question. So, the correct answer to this question would be option D, an eruption cyst. To review, an eruption cyst is a soft tissue cyst that results from a separation of the dental follicle from the crown of an erupting tooth. Fluid accumulates in this follicle space, leading to the swelling appearance. Typically, there's no treatment needed because the tooth can erupt through this lesion. So, to summarize what we learned today,
First, we learned about common neonatal lesions, including Epstein Pearls, bone nodules, congenital epuli, natal and neonatal teeth, as well as eruption cysts and hematomas. We also learned about some common developmental and inherited conditions in children, such as Down syndrome, autism, fetal alcohol syndrome, and obstructive sleep apnea. Thanks so much for joining, and we'll see you next time in our lecture series. Bye.